Hey everyone, welcome back to another video. And so today we'll be continuing the lecture series in social medicine part 2. Today we'll be focusing on lecture 3, which is epidemiology. Definitely a tricky one. We will be skipping lecture 2 as it's a bit more straightforward, and yeah, we have a lot more tricky lectures to go through. So yeah, let's just get into it. So with epidemiology, the definition is studying the distribution and determinants of disease in the population. Now, determinants just mean the risk factors. So basically, we're trying to discover how does one get a disease and how is it distributed in the population. All right. Now we'll see later on indicators and studies to help us be more informed of this. And we will look into the idea of causality with the Bradford criteria. Okay. Now, with epidemiology, you have two types of epidemiologists which study epidemiology. First, you have the epidemiologists that focus on non-infective epidemiology, and secondly, we have epidemiologists that study infectious disease epidemiology. And now with the first type, these guys focus on one population. The reason being is there isn't a population to give a disease, to pass a disease on to another, which would be infectious disease epidemiology. However, here we only focus on one population. So with this, we can identify the risk factors which are usually identifiable, and these risk factors cause cases. Now, when we say cases, we just mean this certain disease, all right, or a certain event. And so this identifiable cause causes or produces cases. All right, so identifiable means is just that we know for a fact that A causes B. Now, if we look over here in non-infective category, we can see a tumor on someone's arm. Now, we can say that this tumor was caused by a genetic mutation, and so A would be a genetic mutation and B would be the cancer, which is the new case. Okay, now if we compare this with infectious epidemiology, here we focus on two or more populations. Reason being is we now have more populations. We have a population that is the infector and the receiving population, the infected. All right. Now, this is a little different because we have infectious disease, which is contagious. The cases now are risk factors. So here the rat, which we can say A, passes the disease on, which is B, to the human. The human now has become a case being infected with the disease. But now what's different between the two is now B is a new risk factor, meaning he can now spread the disease to other people and he can spread it to other people. The risk factor has become the case has become the new risk factor. Here, the risk factor causes a case, and that's it. And now with this risk factor, they are generally not known, right? There are usually multiple reasons It's not a simple A causes B, but A can cause B, which causes C, or it could be D, which causes B, which causes C, E, which causes B, which causes C. There could be different reasons why we get C. All right. One of the reasons could be is that we have multiple populations, and of which they produce their own risk factors. Now, as we'll see here, we'll look into this a little bit more. So with epidemiology, we have 7 tasks, first of which discovery. So here we're discovering the risk factors, and it can be A for agent, it can be a virus or some other pathological agent, H for host. It can be from a certain population, such as rats, and E for environment, such as pollution. Now, determining the importance of the illness, the important word is the importance. Here we want to categorize and rank in terms of importance the risk factor. This is tricky, however, it is beneficial. Identifying. Here we want to identify which aspect of the population is more at risk, and how do we do this? We do it through risk assessment. Certain indicators we can use, as we'll see later on. And so you may think, or to put into perspective, population A and population B, and let's say we are focusing on hypertension. If we have group A, and group A is they have some genetic predisposition for hypertension, and group B have some lifestyle problems or dietary problems, which is more susceptible to cause hypertension? This is the idea. Evaluating. So here it's pretty simple. We just wanna look at the preventative measures, the health services. How does it prevent the spread of disease? Study, especially studying the natural history of disease. This is important in preventing spread of disease, as we will see in a minute. And it's related to evaluation in the sense of health prevention. Conducting, we want to conduct surveillance, different studies, as we'll see later on as well. This will help us in terms of epidemiology studies and investigation. We can have infective and non-infective spread of disease, or infective and non-infective outbreak. We can have epidemic and pandemic outbreaks. Okay. Now, moving on, we have to know a case study on Jon Snow. And so in terms of Jon Snow and his work in epidemiology, or what he brought to the table, basically all you need to know is that he identified how epidemiologists can or should think in terms of how a disease is caused and spread. This is the general definition of epidemiology. And so in a nutshell, what he did is he denounced the idea that the disease of cholera was spread through the air. He noticed this through the localizing spread or localized increase in cholera cases around pumps, water pumps. And of course we know cholera spread through water. If it was spread through the air, we would have seen a widespread equal distribution in the population. However, we only saw focal increases, which then led him to further investigate and finding out that this is caused by water and not the air. All right. Now, the natural history of disease. So this is pretty much one of the big reasons, the big benefits in epidemiology and what it can bring. So with epidemiology, what's good about it is that if we know the distribution, the cause and distribution of a disease, we can then use this in terms of primary, secondary, and tertiary prevention. All right, so just going over this, primary prevention is basically measures we can do to promote and prevent illness. All right, you can have specific and non-specific. Specific being vaccinations, vitamin D, folic acid. Non-specific can be prophylactic exams. All right, so primary prevention starts when you do not have the disease. However, you are exposed to the risk factor. You're still exposed, however, you haven't contracted the disease yet. But then when we move into secondary prevention, this is where you actually have contracted the disease, but that does not mean you have symptoms. All right. This stage ends when you have diagnosed successfully the patient. However, just to mention, when you have no idea how or what is the etiology, when you have no idea what's the etiology, what do? You move straight away to secondary prevention. All right. If you got a disease and you don't even know how it's caused, all right, you're gonna go and try and get yourself diagnosed. That's basically what it means. So with secondary, you have non-specific and specific. Non-specific can be, your prophylactic exam, and your specific can be things like screening. All right. Now, screening can be for specific illnesses, like it's usually cancer, breast, cervical. All right, and something to take away from this video is that screening is a risk assessment. Remember, in the lecturer was talking about how you do not want to say it's a diagnosis, because screening is not a concrete diagnostic tool. It should be used as a contribution in terms of the overall diagnosis. All right, so you do not want to mention it's a diagnosis. You don't want to do that. And finally, tertiary is all about how we can prevent the impact of a disease. So what I mean by this is limiting disability. All right. We want to reduce the impact a disease has, or we want to rehabilitate the patient, get them back into the wider society. Now, if we focus on these 6 stages up here, no disease is primary prevention. These 3 stages here, disease onset is when you get the disease, asymptomatic period, this is like your incubation period, clinical diagnosis, this is the end of the secondary prevention in which you have been diagnosed. Then disease development, this is when the disease is progressing. And tertiary prevention, disease resolution. Here you have 3 options for disease resolution: a cure, complication, or death. All right. Do you get over the disease? Does it become chronic? Or do you suffer from the disease and die? All right. So this would go under tertiary prevention. All right. All right. Now something a little less complicated than that. Causality. Now you all must have heard the idea of correlation is not causation. So I just want you to keep this in mind. Alright, we'll get back to that. So what is a cause? Or a cause has 3 predispositions. It should be associated with its effect, it should be before or at the same time, and it should act on the effect. So let's use this for an example. A, which is the cause, should cause B. If A is a cause, it should have an effect on B. Alright? If A is the cause, it should be before. So this is before and this is after. And it should have some effect. So if rates of A go up, then B should change, either going up or down. It shouldn't just stay stationary. Alright? Actually, there's one thing I just want to quickly point out. Disease development also means that we try to treat the disease with current methods of treatment. So here we try to treat with current methods of treatment. So yeah, tertiary begins with disease development and progresses to the resolution. Alright. So interaction of events. Now again, keep it in mind, correlation is not causation. Correlation can be synonymous with association. Association and correlation can mean the same thing. So events can be associated, alright, or correlated. And what this means is there is a statistical link. However, this doesn't necessarily mean there is causation. Alright. So the 2 types of events you can have. Alright. First of which is non-associated. You can have non-associated events and associated events. And what did I say? Associated means correlated. So non-associated or independent events, A has no effect on B. Alright. But associated events or correlated events have some statistical or correlatory impact on B. However, again, I want to mention one more time that this does not mean there's a causation. Alright. Where we do get into the idea of causation is when we look at if it's causally associated or not causally associated. Causally, is there any causation? All right. So is the event indirectly associated? All right. Or is it directly associated? And so if it's indirectly associated, well, it pretty much means that A does have an impact on B, but first it has to go through C in order to have an effect on B, and if it's direct, A has a direct effect on B. Alright, that's causally associated. However, not causally associated can be a statistical association. Alright, so this is the idea of correlation doesn't mean causation. If something is correlated, statistically associated, does not mean it's causally associated. So the word here is parallelism. Yeah. Just because A is having an effect on B and it looks like there is some causation does not mean it is, and that's parallelism. Yeah, this is a bit weird to get your head around. Even I'm struggling a lot with this lecture, but yeah, just keep going over it. I'm sure you'll get a grasp of it. All right, let's move on. Now there are different factors. Well, there are different interaction types with factors and the effect. All right. Here we have factor A and event B. All right. Now here we have different configurations, and so we'll just go through each one. Firstly, factor A is necessary and sufficient. So this basically means that factor A is needed, all right, and it's needed, and it's the right type of factor to cause B. So let's say risk factor A is a genetic mutation to cause cancer B. So this mutation has mutated X amount of genes, and the idea of having a mutation being sufficient, both of these is necessary and sufficient, and so therefore this is the first type of configuration. Factor A can be necessary and sufficient. Okay, it's a weird one, but you just gotta go with it. Next, factor A is necessary again, but now it's not sufficient. All right. So here it's basically saying that A by itself can't cause B. All right. It's needed to cause B, but it's not solely primarily responsible. All right. So let's say B is TB. Let's say B is TB. All right. Let's say A is Mycobacterium tuberculosis, However, this isn't enough, all right? And so we need C, which is immunocompromisation. Both of these combined causes B. However, if we were just to have Mycobacterium tuberculosis, it wouldn't be sufficient to cause TB in a, let's say, in a more severe sense. All right, let's the secondary post-primary type. Let's just give an example like that. All right. So A is necessary to cause TB because obviously we need the bacterium. However, C is needed as well. All right. Moving on, factor A is not necessary, but it is sufficient. All right. So basically it's saying here that factor A can be replaced by other factors which can cause the disease. All right. So A can cause B, however, C can cause B. It doesn't need to be like this one over here when we just said both two factors need to be combined. They can be independent in this instance, all right? So it's not necessary for in order to get B, A has to be the factor. C can be the factor, D can be the factor. So it is sufficient. It does cause the disease, however, it's not necessary. So this, you can imagine, can be something like atherosclerosis. So with these type of vague open book diseases like atherosclerosis, hypertension, that sort of thing, obviously you can imagine there's multiple different etiological risk factor, primary, secondary, different risk factors you can have that can lead to atherosclerosis. There's not just one factor. However, they each play their own part. All right, now finally there is factor A is not necessary and is not sufficient. All right, so here factor A is not necessary, so A is not even needed to cause B, so we don't need A, and it is not sufficient to cause B. So it's not it wouldn't cause B if it was solely the sole factor, right? So it's not necessary with C, and it's not even as a sole factor, not responsible for causing B. Now, what I've put down in my notes, A can increase or decrease getting B. So A can be a factor which increases the likelihood of getting B or decreases the likelihood of getting B. All right, so that's why you see positive and negative. A doesn't have to increase the likelihood, it can decrease it as well. All right, now Bradford Hill. So pretty simple here. Bradford Hill was an individual who published a book basically giving a outline or criteria, different criteria, specifically 9 criteria in basically justifying how we can identify causation to be more believable. And so this is what I mean. So the criteria for causality in epidemiology. causality for epidemiology. And these are the 9 criteria. Alright. First, he mentioned you need to have strength of association. Alright. The more associated A is to B, the more likely it is a causal relationship. Alright. The more likelihood A is related to B, the more likely it's causal. Strength of association. Number 2, consistency. Basically, this relationship, this this relationship can be actually replicated by other people in other places as well. So if you found there was an association between A and B, if you found this, someone else should be able to determine if that is the case, and they should get the same outcome as well. So it should be, the strength should be associated, strength of the association, it should be consistent with other people. Specificity of the association. Now this basically means the more accurate the exposure is, the stronger the relationship is. Alright, so the more accurate, the more stronger the relationship is. Alright, so like diet and coronary heart disease, it would be more stronger association than let's say sitting or something like that. Temporality. So this basically means that is the risk factor acting before the disease. Alright, is A the cause? Is it actually before B the event? This is important because we'll see later on the idea of incidence studies and prevalence studies, alright, and the idea of cohort studies, alright. It's important because with these incidence studies and with time, this will make sense later on, but when we have time, when we have incidence studies, we're able to infer there is a causative relationship. Alright, so to conclude A causes B, there has to be an element of time, and this is associated with incidence studies, or studies that include time, usually time in a prospective manner, not a retrospective, a prospective. And so prospective is usually synonymous with, I just messed that up, prospective, and that can be synonymous with cohort. Alright, factor 5, the biological gradient. So this basically means the more or less you're exposed, this will cause a change in the disease. So more exposure or less exposure can cause more of B or less of B. Plausibility. Now, plausibility means that this association, it must be within the realms of general knowledge. Yeah, you can't just pull something out of the magician's hat, right? It has to be something that is relevant, something that's known in the sphere of knowledge in that time. All right, so this is all about knowledge and consistency. Now with experiment, changing the risk factor changes the outcome. So instead of A, if we have B as the causative risk factor, this would cause C. So A would usually cause B. However, if we get rid of this and have B, it would cause C. And finally, analogy, association may resemble similar events. So what I was trying to say here is that the association between A and B may resemble maybe another factor. Maybe C may cause B and A may cause B. So they're similar, the associations here, they are similar. I think that's what that's trying to say. Obviously, I'm not 100% with all these. Well, at least this one. And yeah, coherence. Yeah, all the observations must fit with the model. So whatever you've hypothesized, the observations should be coherent. Now, in the lecture, we were told about confounding, not compounding, but confounding factors. All right. Now, we were told that confounding factors, make sure you always say these two things. Number one, we should have age. And number two, we should have sex. Now, age and sex has to be confounded. Now, what confounding factors mean is that factors may have a relationship with other factors, which then leads to a certain disease. So let's say liver disease is the disease. No, actually, let's say lung disease. Lung disease. All right. Now let's say we have an individual here likes to drink alcohol. All right. Let's say his life isn't going as well as he wanted. You know, he's broke up from a marriage. He's lost his house or something. You know, whatever happened. And basically, the more he drinks, the more he's spiraling into, you know, a dark place. And he's like, you know what, I'm gonna start smoking. And then from smoking, does this then increase the likelihood of getting lung cancer, lung disease even, whichever. As you can see here, there's a dotted line here. Drinking does not cause the lung disease or the lung cancer. However, it's this idea of confounding factors, this kind of gateway notion, in that this person or people who drink are more likely to smoke, and it's through this kind of stereotype, you can say, is that, or confounding factor, you can say, does this then cause the disease? So A, which is drinking, can cause B, which is smoking, which can cause C, which is lung disease. However, A doesn't cause C. All right. This is, like I mentioned, this is going to be a long one. But hopefully you are still on the same page. So yeah, let's start. Incidence. Now, incidence is basically a measurement we do or use to find out the proportion of new cases of a disease in the population at risk. The important thing here is that we are taking into account time. All right, time is at play, and so with this, we are able to have a prospective visual measure. So here we can actually estimate the new cases of a certain disease because we are focusing on time. All right, so it's not a static measurement, it's a dynamic measurement. So here we look at a population and we look at the risk factors affecting the population. This will cause cases, so we are looking at cases over the population at risk. Now with odds, here we do not have a time element. However, here we just have cases over non-cases. So here we don't have the population at risk, we have cases over non-cases. This will give us an odds ratio, and we'll see later on the importance of that. Now, what's the difference between this and prevalence? Well, you can see prevalence does not involve time. There is no time here. And so because of that, we can't infer, we can't make a projection of the disease. Here, we actually look at a point in time. If you can remember, we have population statics, and dynamics is the same thing with population statics. Here we're looking at a point in time. However, the interesting thing here is we can actually look at new and old cases. The reason is in the pink here, or the red, you can actually see new cases. However, you can actually have old cases that have not been, let's say, treated, and it has projected all the way into your field of study, which is the present day. All right, so you can have both new and old cases, but the same thing remains. You're looking at the population at risk. All right. And so with this, prevalence and incidence, these both give their own benefit, and with a high and low incidence or prevalence, it can have different impacts, all right, or different reasons why it's the case. All right, so a high prevalence means that the current level of treatment right now isn't sufficient, and incidence high means the preventative measures aren't sufficient. And so with that information, you can basically deduce all the different configurations, keeping in mind that prevalence is all to do with present treatment and incidence, because this focuses on the future cases, is to do with prevention, and this can be specific to primary prevention. Prevalence is more associated with the secondary and the tertiary. So yeah, risk assessment here. We are looking at studies here, and the risk factor is smoking with our population, and we can see people who get the disease and people who don't, and we compare this with those that did not have smoking. So this is your comparison group or control group. This is the experimental group. All right. So as you can see here, the incident exposure, 250 with the case, which is cancer, divided by the population at risk, 1,000 people, we get a value 0.25. All right. And the odds ratio, as you remember, it's cases over non-cases, 250 over 750, we get a value 0.33. All right. Now, what do these risk assessments, what can they tell us? All right. So with incident exposure and incidence non-exposure, right, these measurements can give us certain indicators. I was trying to find the word then. So with these indicators, relative risk, attributable risk, odds ratio, they give us different indicators. And so what is relative risk? So relative risk, here we have to do a division function. This gives us an indication in the increase or decreased factor in being contracted with that disease. So here we can see there's a 5 times factor for gaining a disease when we have incident exposure 0.25 and incidence non-exposure 0.05. So here they've done this risk assessment. Here they got the incident exposure, and here they got the incidence non-exposure. So the incidence exposure was here due to smoking, and incidence non-exposure, there was no risk factor here. The exposure was the cancer. The non-exposure, because there was no risk factor, still gained the cancer. It gives us a factor of how many times you have of a risk getting this disease. But with attributable risk, here we get a value in the likelihood of you getting a disease, or the increase in risk of getting a disease. So same thing, but here we're doing a minus function. And so if you do smoke, you're 0.2 times likely to get this disease. All right. Or it's basically the contribution of this risk factor that changes the likelihood of you getting this disease. So if somebody smokes, we see that there is 0.2 cases per 1,000 they get this disease. Now finally, with the odds ratio here, because time is not involved, like I mentioned before, there's something called cohort studies, and cohort studies have time involved. Because this has time, we cannot use this in a cohort study, right? We have to use it for non-timed studies, and this is your prevalence studies. Prevalence studies. All right. Now, relative risk assessment. The relative risk. This is actually important because with different studies, you'll see when you're reading certain articles, you'll see that they include these values, relative risk, and it goes from basically it's 1 and less than 1 and more than 1. All right, that's basically all you need to know in terms of the scale. However, if we have a relative risk value of 1 exactly, that risk factor is not protective and it's not destructive. All right, so let's say I drink 4 glasses of water a day. All right, if I drink 4 a day, I'll get a relative risk factor of 1. Obviously, I'm just making a stupid example there, but if I drink 4 glasses, this will not be a high amount to actually cause me danger. However, it's not too short, not give me any protection. All right, I think I got that right. So that's exactly 1. Oh, you can see the scale over here, 1 to infinity. So if the relative risk factor was less than 1, it's a protective factor. All right, so if I do exercise 1 hour a day every day, and I get a value, let's say 0.67 RR, relative risk, that's a protective factor. It basically means that risk factor you're doing, that exercise you do for 30 minutes or an hour a day, gives you protection against whatever disease we're interested in. And then with the value above 1, this actually causes a risk factor. So if I eat 3 Big Macs every day, right, and I get a value of like 2.3, this indicates that what I'm doing, or what that risk factor is actually causing a negative effect. All right. Whew. Right. So yeah, that was a large, very time-consuming, I know. Because of that, I'm gonna cut this video here. This is not the end of the lecture, by the way. This is the last part of the lecture, epidemiological studies. So I'm going to leave it here, and I'm going to continue this in the next video, in part 2. All right. So yeah, hope you enjoyed. See you soon.